Yeah, so let's start. And just at the beginning, I just want to show the picture for our understanding how changed is the life of our patients for years. Because before insulin era, they were looking like that, and now our patients are very active, very modern, they're living with high quality of life, and we just need to understand that when we're talking about diabetes in children, adolescents, and young adults, it's not a story only about type 1 diabetes, it's also a story about type 2 diabetes, about MODY, and about other forms of diabetes, how we can choose the typical form of diabetes for this category of patients. There are a lot of ways to understand what type of diabetes your patient has, but I just want to emphasize that here, now we have some suggestions that it's not only possible to be obese in pubertal age, even before, because now we have a growing epidemic of childhood obesity, and we need to remember it when we're talking about type 2 diabetes. It's easy to understand, and you can realize now that also patients with type 1 diabetes have some common things with type 2 diabetes patients, such as overweight obesity in half of the patients, low HDL level, elevated triglyceride, hypertension, dyslipidemia, and even polycystic ovarian syndrome, and we need to remember it when we're treating our patient in the correct way. There are a lot of studies now and a lot of research which conclude there are different attitudes in every different type of diabetes, and we can understand just looking at this picture very quickly. What should we do like an algorithm? We just need to understand what is going on with our patients, and if you will just check this algorithm, you can easily understand what type of diabetes your patient has. So the first conclusion for my presentation, it's that diabetes in children, adolescents, and young adults, it's not equal to type 1 diabetes only. It's also possible to have type 2 diabetes, MODY, and other forms of diabetes. If you will just talk briefly about type 2 diabetes in these patients, of course there are a gross epidemic of obesity, as I told you before. But the main thing here is there are a lot of genetic differences in these patients. And if you are talking about type 2 in childhood, adolescence, and young adulthood, we need to remember that microvascular outcomes are more rapidly and aggressive here. So we need to put our attention to prevention of complications of diabetes. What is the reason the concerns about type 2 diabetes in the young population? Because they have longer period of hyperglycemia, which can lead to longer prevalence of chronic complications. And of course, they are less likely to be aware of type 2 diabetes or cardiometabolic risk factors because they are too young for that. Also, it's very important to remember, and this study was just published this month in Diabetes Care, that younger patients has more severe cardiovascular risk factors than older patients, and we need to keep it in our minds. The problem here is that in all our very important and big randomized controlled trial, we are not really have enough information about young patients with type 2 diabetes, because if you can just look here, the mean age of all participants in all our studies is higher than young age, so we need to remember about it. So the simple fact, as a second conclusion, it's also type 1 diabetes remains the most common form in diabetes in children, adolescents, young adults. The recent unabated increase in obesity just lead us to the prevalence of type 2 diabetes in these patients. What should we do when we are talking about assessment through the lifespan? We just need to remember that all these ages have their sort things for think about, and so we have a lot of problems here in our adolescent population and in young adults. Why it's so hard? Because we just need to remember about some psychological issues here. There are some key development tasks of adolescents and young adults. First of it is like separating from parents, and the second, they become an individual able to independently form opinions, ideas, and goals. And that's the reason for worsening of diabetes control for our young patients. Because if we just look to research on it, adolescent young adult patient conflict is associated with worse adherence, worse metabolic control, worse quality of life, and increase of depression symptoms here. So what should we do? We just need to remember about barriers to success, about burnout, about inadequate motivation and support, fear of an actual hypoglycemia, weight gain, and we need to remind our patients about blood glucose monitoring, which you need to apply very frequently. In addition, we have a lot of comorbidity in this period of life, and the very important issue here is to remember about depression and about high risk for eating disorders and substance misuse. Another issue is weight gain, and it's a very important issue for girls with type 1 diabetes, because they all need insulin injection just to lose their weight. And you know information about eating disorders. It's very easy to get a lot of complications because of it, but it also can lead to increasing rate of mortality for our young patients. Just to conclude this part, I just want to remind you that there are a lot of issues for this age, and we need not to forget about alcohol usage, about smoking, about illicit drugs that our young patient can use. And there are some suggestions, for example, from one Australian study, that a lot of our adolescent patients and young adults use something, and we also need to remember about pre-pregnancy counseling, even for young adults, even for late adolescent period, because it's very important. And of course, because a lot of psychological issues here, we really need psychologists or psychotherapists in our diabetes team, and it was written in guideline from ISPAD. Another option here that we need to remember, that importance about transition from childhood endocrinologist to adult one. So they completed school, living home, become financially independent, getting married, having a child. That's the reason that we need to transition very attentively our patients. And we need both working as a pediatrician endocrinologist and also adult endocrinologist here before the years of transition. And there are some very easy recommendations for making this process very easy. So what we have, what approaches do we have for overcome barriers in adolescents and young adults? Right diagnosis is important. It's not equal only for type 1 diabetes. Family support, psychological issues matters. Flexibility, dietary and management plans is very important for this patient. Extended outreach and support, providing realistic expectation and achievable goals for them, and help in transition. So as I conclude here, that adolescence is a difficult period of time, but we need to remember about key development tasks for this period. So what about glycemic goals? We need to remember that we need to be as close as possible to just a lot of levels here, but the main issue is written here, that we need as less level of HbA1c without hypoglycemia risk increasing. And as a conclusion here, we can just say that for successful glycemic management, as Mina said before, we have HbA1c measurement at least quarterly, glucose monitoring using CGM or self-monitoring blood glucose very oftenly, and regular review of glucose levels with therapists adjusted as necessary. What about treatment? I just want to say about some problems with patients of MDI, with type 1 or type 2 patients and young adults. So what we can do here, we just need to check the adherence to insulin injection, the insulin injection technique, insulin injection site, maybe for blood glucose testing, frequency, and everything about hypoglycemia. What can help us is modern technology. Again, it's like pumps and sensors. I don't want to speak much here because Mina said it perfectly before me. I just want to add that now we have essential components of diabetes control. First is like HbA1c level, of course, self-monitoring blood glucose, and sensor usage. Why? Because for our patients, life is like life as an art of balance, and they're worried about hypoglycemia. That's why we can conclude that hypoglycemia is a major limiting factor in the glycemic management of diabetes in young patients with diabetes. What are the symptoms of glycemia modifying factors? I just want to show you it because, as you can see here, there are a lot of issues which are connected with young age of our patient, like aging, drugs, alcohol, sleep, posture, and so on and so forth. And there are also some psychological consequences of hypoglycemia, with short-term or long-term, with a high list of things here. And what is the reason why hypoglycemia is feared? There are a lot of them. So as conclusion, we just can add that fear of hypoglycemia is also maybe a cause of avoidance behavior, which creates a barrier to good glycemic control. So just to be more practical, I just want to be helpful for you as a clinicians. There's a practical step for reducing the amount of hypoglycemia in this age group. Carb count and skills education again, rectify basal to bose ratio, brindle bose, soften correction, rest lipohypertrophy, like side problems, don't need to direct control. We need to mention everything about exercise, alcohol, and so on and so forth situation, and we need to pay attention to all ages. What about long-term complication of diabetes? Of course, we can just speak a little bit about this complication even in young age. Because of course it's like not very popular in this population, but still we have some data from different countries with high level of diabetic complication even in young patient. And as a conclusion here, we can just say that in areas where healthcare is not optimal, like for example in my country, a greater risk of complications still exists. What we need to remember about initial evaluation and follow-up in adolescents and young adults, of course, diagnosis, review of symptoms, diabetes history, family history, current treatment approaches, assessment of patient psychological and educational needs, but we also need to remember about evaluation for diabetes complication or other things. And of course, we need to have a correct follow-up plan for them. What should we do here is just written in all guidelines, when we need to use it very often, just read for all chronic complications of diabetes, even for macrovascular disease, not only about microvascular. And we also need to remember about main issue, about quality of life, not only about target glucose level or time and range level, not about hypoglycemia, not only about chronic complication, but about quality of life. And what will help us here, of course, we know a lot about treatment of diabetes, about modern modalities, and thank you, Nina, for perfect presentation of that. But what are pumps, sensor, insulin analog, so on and so forth. But what is the base for this? It's education. And there are some issues connected with education for this category of patient, for adolescents, young adults. It's building trust in relationship. It's very important. Clarify priorities and set achievable target here. Encourage our patients to have a better control, offer a variety of educational opportunities, not only official way like teaching in hospitals or in outpatient clinic, but also we can use social media, internet resources, some video games, CDs, and so on and so forth. But we also need to help parents or families as they change their role from full responsibility to another option. So, as conclusion, I just want to tell you 10 main take-home messages for the topic of diabetes in youth. First, diabetes in children, adolescents, and young adults is not equal to type 1 diabetes only, especially now when the level of obesity in childhood is growing. We need to include young patients with type 2 diabetes to randomized controlled trials for better understanding of cardiovascular risk factors. Third, adolescence is a difficult period of time, but we need to remember about key development tasks of this period. They want to be independent from us and from their families. Goals are an issue, as low as possible without hypoglycemia risk increasing. Treatment needs to be effective. We can use technology here. Hypoglycemia is a major limiting factor in the glycemic management of diabetes. It's still an issue. And fear of hypoglycemia may be the cause of avoidance behavior, which creates a barrier to good glycemic control. Prevention of diabetes complications is very important in this age group. Psychology matters, and it's still an option here. And of course, with education, we can change everything in lives of our patients. Thank you for your attention. Thank you for my patience to inspiration. And still, if you need something from me, just contact me in every way you want. Thank you.